Imagine a massive medical crisis. A patient's lungs are just desperately struggling to keep up. Now, for decades, the go-to solution for this meant inducing a coma and inserting a breathing tube directly into the windpipe. Pretty intense, right? But what if we could support those exhausted lungs from the outside? What if we could keep the patient totally awake, comfortable, and avoid those invasive procedures entirely? Well, welcome to The Explainer. Okay, let's dive into this and explore the core mechanics of exactly how we do that with non-invasive ventilation.
Here's our roadmap for today. We'll start with what non-invasive ventilation actually is, then look at acute medical applications, chronic and home use, a quick history of the technology, and finally how it's all applied in real-world hospital care.
Section 1. What is non-invasive ventilation? Let's get into the core definitions.
And this brilliantly illustrates the difference. On one side, you've got traditional invasive ventilation. This requires intubation, literally passing a tube right down the windpipe. It requires heavy sedation, and honestly, it carries some pretty significant risks of infection. On the flip side, we have non-invasive ventilation. Just like the name implies, it doesn't invade the airway. Instead, it relies on a tightly fitted interface. Think of a face mask securely over the nose and mouth, or even a transparent helmet. It delivers that vital support from the outside in. The best part? The patient gets to stay awake, they can communicate, and they actively participate in their own care. It is an absolute game changer.
So let's get down to the formal definition. Non-invasive ventilation, or NIV, is breathing support that delivers alternating pressurized air right through that tight-fitting mask. Now, you might already be familiar with CPAP machines, right? Those deliver a single continuous pressure. But NIV is different. It's dynamic. It actively alternates the pressure. When you inhale, it gives you a higher boost. That's called IPAP, or inspiratory positive airway pressure. And then, when you exhale, it drops down to a lower resistance, which we call EPAP, or expiratory positive airway pressure. It's basically actively mimicking and assisting your natural breathing cycle. You might also hear it called NIPPV, or maybe even by the old brand name BiPAP. But in the clinical world, we generally just stick with the term NIV.
Moving right along to Section 2, Acute Medical Applications. Let's talk about emergency scenarios. Now, what's really interesting about this is how versatile it is in a bustling emergency room. This technology manages a huge variety of crises. The most common trigger for acute NIV is a severe flare-up or exacerbation of chronic obstructive pulmonary disease, or COPD. But its reach is really vast. It tackles acute heart failure when fluid rapidly floods the lungs. You'll hear that called cardiogenic pulmonary edema. It was an absolute critical lifeline during the COVID-19 pandemic, when invasive ventilators were incredibly scarce. Plus, it helps cystic fibrosis patients clear out high volumes of sputum. And it even steps in for post-operative respiratory failure, when a patient's lungs just need a little extra help recovering from a major surgery.
But how do doctors actually know when it's time to turn the machine on? Well, when a patient's lungs fail to clear out carbon dioxide, it starts building up in the bloodstream and literally acts like a toxic acid. Clinically, this mechanism is called type 2 or hypercapnic respiratory failure. To spot this, the medical team uses an arterial blood gas test, or an ABG. They are looking closely at the blood's pH level. When that pH drops below 7.35, boom, that is the trigger. That tells the doctors the patient's breathing muscles are totally exhausted and they urgently need the mechanical muscle of NIV to help blow off that trapped carbon dioxide and restore the body's balance.
All right, Section 3, Chronic and Home Use. Let's look at long-term care.
You see, for many people, respiratory failure isn't just a sudden one-off emergency. It's an everyday chronic reality. The long-term use of NIV, which we often just call home NIV, has actually been shown to improve daytime carbon dioxide levels and even boost survival rates in people with severe, stable COPD. But it's also absolutely crucial for other groups of people too. Take patients with progressive neuromuscular diseases, like motor neuron disease. They gradually lose the physical muscle strength needed to breathe on their own. Home NIV steps in and provides that missing mechanical strength. It's similarly vital for folks with significant chest wall deformities, where the actual physical mechanics of breathing are compromised, and for those dealing with obesity hypoventilation syndrome. Let's actually look a bit closer at obesity hypoventilation syndrome, or OHS, because the treatment path here is pretty specific. According to clinical practice guidelines, doctors rely on sleep studies to figure out the exact right tool for the job. If a patient has both OHS and severe obstructive sleep apnea, the initial treatment of choice is actually CPAP, that single continuous pressure we talked about earlier. But for the roughly 30% of patients who have OHS but do not have severe sleep apnea, NIV is the primary go-to. It's much more effective at clearing out that stubborn carbon dioxide, even though it does require a bit more resources and setup. And of course, if a patient tries CPAP and it's just not getting the job done, the clinical team won't hesitate to escalate their care directly to NIV. Section 4. The history of NIV. Let's see how this builds over time.
Looking at the timeline, you quickly realize that NIV isn't some brand new modern invention. Its earliest uses actually stretch all the way back to the 1940s, but the modern era of NIV really kicked off in the 1980s, when doctors started using it for people with chronic respiratory muscle weakness. Then, we hit a massive paradigm shift in the 1990s. Clinical trials proved without a doubt that using these masks could improve gas exchange and successfully keep patients off those invasive breathing tubes. That discovery spread like wildfire, leading to widespread adoption across intensive care units and pretty much transforming critical care overnight. But as you know, rapid growth brings its own challenges. By 2017, a major report in the UK highlighted that because NIV had become so ubiquitous, there were actually some real problems delivering high-quality, consistent care across all these different hospital settings.
Finally, Section 5. Real-world hospital care. Let's look at some protocols in action.
To ground all this theory, let's look at the specific protocols at West Suffolk Hospital as a real-world model. Because NIV requires specialized, close monitoring, you can't just place a patient on it in any standard hospital bed. At West Suffolk, this care is strictly divided into two primary locations. First up is the respiratory ward. Now, this isn't your average ward. It features a specially designed Level 2 bay. That simply means it's equipped with the higher staffing and advanced monitoring capabilities you need to safely manage NIV. The second location is critical care, which encompasses high dependency and intensive care units. This is strictly reserved for the most acute, unstable cases that need continuous, moment-by-moment observation. And all of this specialized care is overseen by dedicated respiratory consultants, like Dr. Thomas Pulamud or Dr. Ludmila Shulgina, making sure there's expert, evidence-based oversight at all times.
But what is the actual experience like for the patient lying there in that bed? Well, the West Suffolk Hospital Patient Guide addresses this directly. They tell patients, you will feel a gentle flow of pressurized air pushing through the mask. It may feel a bit strange at first, but most patients adapt to it quickly. I love that. It's such an empathetic and crucial point to make. On a human level, it's just a non-invasive, gentle flow of air designed to bring immediate relief. But behind the scenes, it requires incredible nursing care. The staff has to constantly balance the mask fit, making sure it isn't so tight that it causes painful skin injuries on the bridge of the nose, but keeping it secure enough to prevent major air leaks that would completely compromise the treatment. It's a real balancing act.
So the crucial point is understanding exactly how this procedure unfolds once a patient actually agrees to the treatment. Here's how it goes down. Step 1, the clinical team carefully fits the mask to the patient's face or head to guarantee a really good seal. Step 2, the machine is switched on and it starts delivering that alternating IPAP and EPAP pressurized air we talked about. This is where the machine actively does the heavy lifting of breathing. It lets the patient's exhausted respiratory muscles finally take a break while the machine pushes fresh oxygen in and flushes that toxic carbon dioxide out. And then step 3, the monitoring phase. The clinical team isn't just guessing if it's working, they are drawing regular arterial blood gases, those ABGs from the wrist, which provides objective, undeniable proof that the oxygen and carbon dioxide levels in the bloodstream are safely stabilizing. Looking back from its early days in the 1940s to the highly specialized respiratory wards we see today, non-invasive ventilation has fundamentally revolutionized how we treat both sudden respiratory failure and chronic breathing conditions. By delivering alternating pressure through a remarkably simple mask, it has literally saved countless patients from the trauma of invasive intubation. But as artificial intelligence and smart sensors continue to rapidly enter the field of respiratory medicine, it leaves us with a really exciting question. How will NIV technology evolve next to perfectly sync with the patient's natural breathing, maximize their comfort, and tackle the unpredictable respiratory crises of the future? Thank you so much for joining me for this explainer. I really hope you're leaving with a much clearer, confident understanding of this truly vital medical technology.